So our recent paper talking about myelofibrosis, current challenges and unmet needs, this was a paper focused around where we felt there were gaps in the field and particularly where we thought there need to be fundamental changes in our approach. And there are many aspects of that and many unmet needs for myelofibrosis patients, but some of them are, this is a very difficult, complex cancer. We should perhaps be treating earlier rather than waiting until the patients become too symptomatic, too big a spleen, too complex in terms of molecular mutations to respond to standard therapies. So that was one thing. If this was a breast cancer patient, we wouldn't be saying wait till you're stage 3 or 4. It's a nonsense, really. And we have very effective therapies. But also, one of the other factors was, how do we measure benefit in the clinical trials? When we use these combination therapies that we're starting to do, why are we still looking only at spleen and symptoms? We should really be looking at other endpoints. Example, allele burden reduction. Example, bone marrow fibrosis grade change. Maybe cytokines, maybe other factors. But as we've seen in the Manifest-2 and Transform-1 studies, if we expect to beat ruxolitinib with a combination of drugs when a second drug might cause side effects and change the symptom response for patients, it's a problem. And then finally, there was a real call out to try to be more inclusive in our clinical trials and think about patients from underserved communities and how we could more broadly represent patients on the basis of ethnicity and culture, but also on the basis of aspects of their disease. Very thrombocytopenic patients are a big area of unmet need, for example. So we tried to bring all of that together, and it's really a call to arms.